Think about being a patient in a hospital for a moment. You're there to get better, and, well, you trust that the people caring for you are doing everything they can.
Right.
But what about all those systems humming away in the background? The stuff you don't see,
Yeah.
specifically designed to keep you safe.
Yeah, that's the fascinating world we're diving into today, patient safety.
Exactly. We've got a whole stack of information here. We're looking at everything from infection control guidelines to the real nitty-gritty of daily medical monitoring and these big safety programs.
It's definitely multi-layered, like a defense system, really, trying to catch problems before they, escalate.
And when something does go wrong, despite everyone's best efforts.
Well, then there are very specific protocols for handling those events. We're going to explore how harm itself is defined. Medically, it's actually more precise than you might think,
Okay.
and how hospitals categorize the different kinds of medical errors that can happen.
And it's not just reacting, right? What's really interesting to me is the proactive side. These advanced tools and strategies hospitals are using now to try and spot risks before they cause issues, to prevent them altogether.
Absolutely. Prevention is key.
So our goal for you today is to walk away with a really clear understanding of these crucial systems, the tech behind SafeCare, without getting totally lost in the medical jargon.
Let's kick things off then. There's this concept of adverse patient occurrences, or APOs.
APO.
Basically, unintended incidents during medical care that unfortunately result in harm to the patient.
Okay.
And when an APO happens, one of the absolute cornerstones, fundamental things, is managing the medical record properly.
Adverse patient occurrences.
Yeah.
Makes sense. So when one of these happens, our sources mention medical record sequestration. That's pretty serious. What is that exactly, and why is it so critical?
It is serious. Sequestration is essentially the meticulous process of safeguarding the authenticity of that patient's medical record right after an adverse event.
Safeguarding authenticity, like proving it hasn't been changed.
Exactly. Think of it like securing evidence. If there's ever a legal challenge in investigation, the hospital has to prove the record is unaltered.
Oh.
Usually the hospital's risk manager steps in. They formally certify the record's integrity before it's released for any legal stuff. It's fundamental for trust and, accountability.
Right, establishing that unbreakable chain of evidence. So how does that actually work? I'm picturing someone literally locking up a paper file.
Well, for paper records, that's pretty much the idea. The original record from that specific encounter where the APO happened gets carefully copied.
Ah, okay.
Then the original, physically secured, often locked away, maybe in risk management. The copy goes back into the regular medical record system.
So patient care isn't disrupted.
Precisely. Ongoing care continues smoothly.
That makes sense. Protect the original, but keep the info flowing for the medical team. But now, most places use electronic health records, EHRs. How does sequestration work digitally?
Good question. With EHRs, the principle's the same, but the methods are, digital. Instead of a physical lock, the electronic record is essentially locked down.
Digitally locked down.
Yeah, to prevent any more modifications. Access to that specific record gets restricted. Only authorized people who absolutely need to review it can get in.
And there's a trail.
Critically, yes. EHR systems have built-in audit trails. Think of it like a digital logbook. It meticulously records every time the record is accessed, any changes made, who did it, when.
Wow.
It provides this really powerful layer of accountability.
That digital audit trail sounds incredibly important for transparency, accountability, all of it. Now, I imagine there are strict rules governing this whole record-keeping process.
Oh, absolutely. Regulatory compliance is paramount. You've got standards from entities like IPA that's all about patient privacy and data security, right?
Right.
And the Joint Commission, which accredits hospitals, they have their own detailed requirements for how records must be protected and maintained. These rules really underscore how vital, accurate, secure records are.
So it's a really robust system designed to keep records accurate, tamper-proof, and our sources even hint at future tech.
Yeah, this is quite forward-thinking. As of 2025, there's active exploration into using blockchain technology.
Blockchain for medical records.
Exactly. To further boost the security and, crucially, the immutability of EHRs, especially when documenting these APOs.
Immutability, meaning they truly can't be changed after the fact.
That's the goal. Creating a record that's virtually impossible to alter later. It could fundamentally shift things around medical liability, patient trust, offer transparency we haven't seen before.
Wow, blockchain. That really is next-level digital security. Okay, so we understand what happens when things go wrong, how events are documented, secured. But let's step back. When we talk about harm in a medical setting,
Hmm.
what does that word actually mean? Seems simple, but I bet it's specific.
You're absolutely right. It is specific. The widely accepted definition, the one aligned with AHRQ, the Agency for Healthcare Research and Quality, is this: unintended physical injury resulting from or contributed to by medical care, requiring additional monitoring, treatment, hospitalization, or resulting in death.
Okay, unintended physical injury. That's key.
Yes, and it has to result from or be contributed to by the medical care itself.
Not just the underlying illness.
Precisely. And it requires some kind of extra intervention, more monitoring, treatment, maybe hospitalization, or, sadly, death.
That distinction feels really important. And this harm, it's not just one thing, is it? It's more like a spectrum.
Exactly. It can range from, relatively minor things, temporary discomfort, needing a bit more watching,
Right.
all the way to the most severe outcomes, permanent disability, even death.
So because the impact varies so much.
You need strong systems to mitigate harm at every level. Absolutely essential. And hospitals are actively tracking this stuff.
How do they track it?
A key tool is the National Healthcare Safety Network, the NHSN. It lets hospitals report and analyze these harm-related metrics.
So they're constantly looking at this data, trying to spot trends, areas for improvement.
Constantly. And interestingly, even the definition of harm is evolving.
How so?
The 2024 AHRQ guidelines, they really emphasize incorporating patient-reported outcomes.
So what the patient actually experiences.
Exactly. It's a significant shift towards being more patient-centered, recognizing that the patient's own perspective on what constitutes harm is invaluable, not just clinical measurement.
That makes perfect sense. Their lived experience is central, obviously. Okay, so we've got harm generally, but our sources also talk about specific types of errors, especially with meds. There's something called the NCC-MERP Index.
Yes, the National Coordinating Council for Medication Error Reporting and Prevention, NCC-MERP, they developed this really useful index. It categorizes medication errors based on the severity of harm they could potentially cause.
A framework for understanding the impact.
Right. Very useful.
Okay, let's walk through some categories. Our notes say Category E is temporary harm needing intervention. Example.
Sure. Imagine a patient gets too high a dose of a drug by mistake,
Okay.
but then they're quickly given an antidote, something that reverses the effects before any lasting damage happens.
So the intervention stops it becoming serious. Got it. What about Category F?
F also involves temporary harm, but it's significant enough that it actually requires the patient to be hospitalized, or maybe extends their existing hospital stay because of the error.
Okay, definitely more severe than just needing an antidote. Then Category G, permanent harm. That sounds really serious.
It is. Category G refers to errors resulting in permanent, irreversible harm, like irreversible organ damage from a medication mistake, leaving the patient with a lasting impairment.
Devastating. And Category H needs a life-sustaining intervention.
Precisely. This category is for errors requiring direct intervention just to keep the patient alive, like needing mechanical ventilation for breathing because of the error's effects.
And then Category I, patient death.
Yes, tragically, Category I represents those instances where a medication error directly contributes to a patient's death. It's a stark reminder of why medication safety protocols are so critical.
Absolutely. Seeing that whole spectrum really underscores the need for prevention. And it sounds like this NCC-MERP index isn't static either. It's evolving.
That's right. The 2024 update specifically addresses errors related to newer, more complex treatments, things like gene therapies.
Those require very specific monitoring, right?
Exactly. Very intricate requirements. So the index has adapted to account for those unique potential risks.
Okay, so systems for documenting errors, defining harm, categorizing med errors. Now, let's shift to how hospitals proactively find these adverse events happening. We keep hearing about the Global Trigger Tool, GTT. What is that? How does it work?
The Global Trigger Tool, or GTT, developed by IHI, the Institute for Healthcare Improvement, it's a really innovative way to identify adverse events that might otherwise, slip through the cracks.
How does it do that?
It works by retrospectively reviewing patient medical records, specifically looking for certain triggers.
Triggers, like keywords.
Sort of. Particular words, yes, but also lab results, specific interventions, things that might indicate an adverse event occurred.
And this complements voluntary reporting.
Yes, and that's crucial, voluntary reporting. It unfortunately only catches maybe 10–20% of actual errors, and many reported don't even cause significant harm.
Right, so you're missing a huge chunk otherwise. The GTK casts a wider net.
A much wider net. That's why it's so valuable.
So how does this record review actually happen? Who does it?
Typically, trained reviewers, often nurses, systematically go through a random sample of patient charts.
Using a list of these triggers.
Exactly. A predefined list of indicators known to be linked with potential adverse events. If a reviewer spots a trigger,
They flag it.
they flag that record for a deeper dive by a clinical reviewer, usually a physician. That physician then determines if an actual adverse event really did occur.
Okay, so it's a two-stage process. Initial screen with triggers, then clinical confirmation. And I see there are key metrics hospitals track using the GTT.
Yes, 3 main ones. First, adverse events per 1,000 patient days.
How's that calculated?
Total confirmed events divided by total patient days in the records reviewed, then multiply by 1,000. It normalizes the count based on the amount of care.
Okay, makes sense. What's the second?
Adverse events per 100 admissions. Similar idea. Total events divided by total admissions reviewed times 100.
And the third?
Percent of admissions with an adverse event. That's just the number of admissions with at least one event divided by total admissions reviewed times 100.
So these metrics give hospitals a way to benchmark themselves, track progress.
Exactly. Valuable data to see how they're doing over time in reducing harm.
And like everything else, it seems tech is getting involved here too.
Absolutely. The IHI's 2025 update for the GTT actually incorporates AI, artificial intelligence, to help with that initial trigger detection.
AI scanning the records.
Yeah. The idea is AI algorithms can analyze huge amounts of data much faster, potentially spotting subtle triggers with maybe even greater accuracy than humans alone.
Reducing the workload for reviewers.
Potentially, yes. And hopefully enhancing the tool's overall effectiveness in finding harm. It's like having an extra set of very sharp eyes constantly scanning.
That sounds like a really significant step, leveraging tech for proactive safety.
Yeah.
Okay, let's dig into some specific triggers the GTT uses. Our notes have a list. T1, neurological deterioration, a drop of 3+ points on the Glasgow Coma Scale. Remind us what that scale measures.
The Glasgow Coma Scale measures a patient's level of consciousness. A drop of 3 or more points is actually quite significant. It signals a worsening neurological status.
And why is that a trigger?
Well, that kind of rapid decline could mean a stroke, a bad reaction to a drug, or some other serious neurological event needing immediate attention. And it could potentially be related to their medical care.
Makes sense. Big changes in neurological function are definitely red flags. T2 is a non-routine postoperative X-ray. What might that suggest?
A non-routine X-ray after surgery could point to a complication from the procedure itself. Maybe a pneumothorax, a collapsed lung after chest surgery, or potentially even a retained surgical item, something left inside accidentally. It's definitely a deviation from the expected recovery. Warrants investigation.
Okay. T3, unplanned return to surgery or an endovascular procedure. Seems pretty clear that's a sign something went wrong.
Exactly. Going back to the OR unexpectedly usually means the first procedure didn't work as hoped, or a new problem popped up needing immediate intervention.
T4 is complications from treatment in the ICU or on the ward. That's broad. Example.
Yeah, it covers a lot. Could be a hospital-acquired infection that developed during their stay, or maybe a severe allergic reaction to a medication given as part of treatment, or even a complication from a medical device being used.
T5, wound issues. With CSF leak, cerebrospinal fluid is an example. Why flag a CSF leak?
A CSF leak, especially after neurosurgery, is serious. It significantly raises the risk of infections like meningitis and can cause other neurological problems too. So any wound issue suggesting CSF leakage, definitely a trigger.
Okay. T6 is CSF circulation disturbances, like hydrocephalus. How's that adverse event trigger?
Hydrocephalus is that buildup of CSF fluid in the brain. It can be a complication after certain surgeries or from other medical conditions. If signs suggest CSF isn't circulating normally, it's a potential adverse event needing investigation.
T7. Nosocomial infections. Hospital-acquired infections with a central line infection is an example. These HAIs seem like a major trigger.
They're a huge concern. HAIs can make patients much sicker, mean longer hospital stays, higher costs, and tragically even be fatal. Central line infections, clebasias, are particularly serious.
From vein lines.
Yes, when bacteria get into the bloodstream via a central venous catheter, often due to issues with insertion or maintenance.
Okay. T8. Readmission to the ICU or hospital within 30 days. That sounds like a strong sign something wasn't fully resolved.
Precisely. Readmission seen after discharge often suggests unresolved issues from the first day, or maybe a new complication arose after going home, potentially linked to the previous care.
Key 9. Prolonged ICU stay due to secondary causes. How's that different from just needing a long ICU stay initially?
It means the patient was admitted for one primary reason, but their stay got much longer because of a new complication or problem that developed during their ICU time, not the original issue.
Ah, okay. And that new issue could be treatment related?
Potentially, yes. Related to treatment or maybe the hospital environment itself.
T10, intubation or reintubation. Clearly a major respiratory event.
Yes. Needing intubation, especially unexpectedly, or needing it again after being weaned off ventilation, suggests a significant respiratory compromise. Could be the illness, could be a complication of care.
And finally, T11 to T13 cover disturbances in fluids, electrolytes, or blood pressure needing treatment. Why are these basic parameters triggers?
Because big deviations from normal in these fundamental areas often point to an underlying problem that needs addressing.
Could be the illness itself.
It could be, yes. But it could also signal a medication side effect, a procedure complication, or another type of adverse event requiring intervention to restore balance.
It's really insightful how these varied clinical events act as clues for potential underlying problems. And you mentioned earlier, sources say these triggers are expanding in 2025 with AI predictive analytics. How would that work?
The idea is to use AI algorithms analyzing patient data in real time, looking for subtle patterns, combinations of factors.
So something bad happens.
Exactly. Trying to indicate a heightened risk of an adverse event before it fully manifests clinically. This could let providers intervene earlier, maybe adjust treatment, implement preventative measures, potentially stop the harm altogether.
That's truly proactive, potentially transformative for safety. Okay, so we've identified events. What's next? Risk analysis. What's involved there?
Risk analysis is that systematic process of evaluating the identified risks, understanding how severe they might be, how likely they are to happen. Two key methods often used are root cause analysis, RCA, and failure mode, and effects analysis, FMEA.
We hear about RCAs after big events. What's the goal?
RCA is essentially reactive problem solving. After an event, you dig deep to find the underlying causes, the fundamental reasons it happened, not just the immediate triggers.
Why it really happened.
Exactly. By understanding those root causes, organizations can change systems and processes to prevent it happening again, digging beneath the surface.
In FMEA, we touched on that earlier, it's more forward-looking.
Precisely. FMEA is proactive. Instead of waiting for something to happen, you systematically examine a process or system beforehand. Identify potential failure points, the failure modes, and analyze their potential effects.
So you can anticipate problems.
Yes, and put safeguards in place before an event occurs.
So RCA looks back to learn, FMEA looks forward to anticipate, and tech is influencing these too.
Yes, the 2024 Joint Commission guidelines actually recommend integrating machine learning into both RCA and FMEA.
Machine learning. How does that help?
Well, ML algorithms can analyze massive data sets to find complex patterns, predict risks, or contributing factors that might be hard for human analysts to spot. It can make both processes more comprehensive, more effective.
Another compelling example of tech enhancing safety.
Oh.
Okay, risks identified, analyzed. What about managing them? Notes mention risk control and risk financing.
Right. Risk control is about taking specific actions to prevent or reduce the likelihood and severity of losses. Several strategies here.
Like what?
Risk avoidance may be eliminating a high-risk service if the potential harm outweighs the benefit.
Right.
Risk shifting, transferring responsibility, maybe through contracts or referrals. And risk prevention, implementing concrete safeguards, like using unit dose medications from the pharmacy to cut down on dosing errors.
Seems logical. Proactive steps. What about risk financing? That sounds like dealing with the money side when things do go wrong.
Exactly. How the organization pays for losses that happen despite control efforts. There's risk retention. The organization sets aside its own funds, often for smaller, predictable claims they can manage internally.
And the alternative?
Risk transfer. Using external mechanisms like commercial insurance policies to cover larger, unpredictable, maybe catastrophic losses.
And there's a newer trend here.
Yes, especially noticeable around 2025 is the move towards captive insurance models.
Captive insurance.
Basically, the healthcare system creates its own insurance company. This gives them more direct control over risk financing, potentially allows for more customized coverage, and maybe optimizes costs long term.
Interesting. A more tailored approach. Okay, we've covered Identifying, analyzing, managing risks. Now, enterprise risk management, ERM, how does that pull everything together?
ERM is a broader organization-wide approach. It's about building a culture where risk awareness is deeply embedded everywhere in all decisions.
Not just in one department.
Right. It involves systematically identifying and analyzing all potential risks, clinical, operational, financial, strategic, developing mitigation strategies,
Hmm.
and crucially, recognizing how risks in different areas interconnect and impact each other.
So a much more integrated, coordinated view across the whole organization. And ERM is evolving, too.
Absolutely. The 2024 guidelines from ASHRM, the American Society for Healthcare Risk Management, specifically emphasize incorporating cybersecurity risks into ERM frameworks.
That makes sense. Data breaches are a huge threat.
Huge. So safeguarding patient information is now seen as integral to overall risk management.
A vital point in our digital age. Okay, let's switch gears to another critical area. Infection Prevention and Control, IPC. We hear so much about HAIs, healthcare-associated infections. Why is IPC so fundamental?
IPC is truly a cornerstone for patient and staff safety. HAIs can lead to significant illness, longer hospital stays, higher mortality rates, and huge healthcare costs.
And there are regulatory bodies involved.
Oh, yes. The CDC, OSHA, the Joint Commission, they all set rigorous standards for IPC practices in healthcare.
And these IPC measures, they're not just for patients, right?
Correct. Comprehensive IPC programs cover everyone, patients, staff, visitors, and all areas of the facility, patient rooms, ORs, even support areas like food service and laundry.
It's everywhere.
It has to be.
Yeah.
It involves developing, implementing, constantly updating policies to prevent infection transmission and managing outbreaks effectively when they happen.
A continuous, all-encompassing effort. And tech is playing a role here, too.
Yes. The CDC's 2025 IPC guidelines, they highlight the growing importance of antimicrobial stewardship, using antibiotics wisely to fight resistance,
Right.
and also the increasing use of AI-driven real-time dashboards for HAI surveillance. These can help spot potential outbreaks much earlier than traditional methods, allowing for quicker, more targeted interventions.
Now, who leads all this? The infection preventionist. What do they do?
The IP plays a pivotal role. They lead and coordinate all the IPC efforts. Their job is diverse analyzing HAI data for trends and risks, conducting ongoing surveillance to track infection rates, developing evidence-based prevention strategies, and reporting data and initiatives back to committees and stakeholders.
So, data analyst, disease detective, educator, communicator, all rolled into one. And their training is evolving too.
Definitely. The 2024 standards from APIC, the Association for Professionals in Infection Control and Epidemiology, now include training on genomic sequencing for outbreak investigations.
Wow, using genetics to track infections.
Yeah, as part of the requirements for CIC certification in infection control, it reflects how important these advanced molecular methods are becoming in understanding and controlling transmission.
Fascinating. Applying cutting-edge science.
Yeah.
You mentioned surveillance earlier. What different types do hospitals use?
Surveillance is tailored to the hospital's needs. There's focused surveillance targeting specific high-risk services or patient groups.
Okay.
And problem-oriented surveillance launched in response to an issue, like an outbreak or a rise in a specific infection type.
It's done professionally.
Yes. Data collection and analysis are done by trained professionals using statistical methods, ensuring the data is accurate, reliable, and gives meaningful insights.
So it's strategic, data-driven,
Yeah.
not just random number collection. And the NHSN is getting smarter too.
Yes, the NHSN's 2025 protocols are increasingly integrating predictive analytics, helping hospitals prioritize surveillance by identifying areas or populations at highest risk in real time.
Makes sense. Using data to be more targeted and efficient. Okay, let's shift slightly to the physical building itself. The Environment of Care, or EOC committee, what do they oversee?
The EOC committee is multidisciplinary. They ensure safety across the whole physical environment. They oversee 7 key areas: general safety, security, fire safety, hazardous materials management,
Okay.
medical equipment safety, utility management like power and water, and emergency management preparedness. They do regular facility surveys, inspections, looking for risks.
Guardians of the physical plan.
Yeah.
And their scope is broadening too.
That's right. The 2025 Joint Commission standards now require EOC committees to incorporate climate resilience strategies.
Climate resilience, like for extreme weather.
Exactly. Thinking about how the hospital prepares for and responds to potential environmental risks, impacts of climate change, to ensure care continuity.
Really forward-thinking, recognizing climate change impacts healthcare directly.
Okay.
Okay, back to documentation. We talked about sequestration for adverse events. What about General medical record review for quality.
That's a systematic process, too. Ensuring records are accurate, complete, meet standards usually involves stages.
Like what?
First, screening. Non-clinical staff use criteria to flag records needing a closer look. Then, sampling a representative sample, maybe 5% or 30 records, gets selected for detailed analysis.
And finally,
Completion. Making sure records are finalized promptly after discharge, usually within 30 days, and that they accurately reflect the patient's condition, treatment, avoiding unapproved abbreviations.
a multi-layer check for accuracy and thoroughness. Crucial for care continuity and safety. And tech is boosting this as well.
Absolutely. AI-powered natural language processing, NLP, tools becoming more common as of 2024 are dramatically enhancing that initial screening.
How does NLP help?
These AI tools analyze the text in records. They can spot subtle patterns, inconsistencies, potential quality or safety issues much faster and more comprehensively than manual screening.
Powerful AI for quality improvement. Now, how about monitoring the professionals? Physician monitoring. How does that work?
Within the medical staff department, various committees regularly review quality management reports on physician performance, usually quarterly.
Some meet more often.
Yes, especially committees doing detailed case analysis and peer review, they might meet monthly. It allows for ongoing evaluation, identifying areas for improvement.
A system of peer review and data analysis for maintaining standards. And regulators are pushing this too.
Yes, CMS guidelines for 2025 emphasize continuous physician performance monitoring, using real-time dashboards to track outcomes, adherence to guidelines.
For more timely feedback.
Exactly, more timely feedback and interventions if issues are spotted.
A more proactive, data-informed approach. Okay, finally, nursing monitoring. The National Database of Nursing Quality Indicators, NDNQI. What's that and what does it track?
NDNQI is a national database collecting reports on many nursing-sensitive quality indicators. The hospital's nurse executive uses this data to monitor and improve nursing care quality.
What kind of indicators?
Key ones include nursing hours per patient day, NHPPD, looking at staffing adequacy, patient falls, incidents, injury levels, effectiveness of risk assessments.
Also pressure ulcers?
Yes, pressure ulcers prevalence and how many are hospital-acquired. Healthcare-associated infections, specifically Club SI, CIUTI, VAP.
And factors related to the nurses themselves.
Right. RN education and satisfaction tracking certifications, but also morale and job satisfaction.
Right.
Recognizing that link between a supported workforce and quality care.
All sound incredibly important for nursing quality and the patient experience, and NDNQI is adapting too.
Yes. The 2025 updates include new metrics reflecting changes in care delivery, things like telehealth nursing indicators and measures of patient engagement in their own care, recognizing these growing aspects of modern healthcare.
It's truly remarkable when you step back and see the sheer complexity, the dedication behind patient safety. It's clearly always evolving, integrating new tech, updating guidelines.
Absolutely. It's a testament to the commitment of healthcare professionals, that continuous drive to learn, adapt, implement new strategies, new tech, all to minimize risk and provide the safest, highest quality care possible. It's dynamic, always changing as understanding grows and better tools emerge.
Considering all these advancements we've talked about today, especially things like AI predictive analytics, real-time monitoring, it really makes you wonder, doesn't it? How might patient care start to proactively adapt before an adverse event even has a chance to occur in the near future? Definitely something to think about as healthcare safety keeps evolving.